We've got one more person. We'll give them a moment to connect their audio. So welcome everybody. There's good news and bad news. I mean, the bad news is Loretta is not going to be with us today. The good news is we've got an interesting presentation in store and a small group. So if you have questions, you'll have plenty of opportunity to get them answered. I think I certainly know Julia, and I've seen Karen on this call previously. And Meredith sounds familiar too. So I probably don't need to tell you all, but this is CIRA's Qualitative Research Discussion Group, or QRDG. Loretta asked me to step in and host today. Um, my name's Daniel. I'm a program director for CIRA, and this is really more of a discussion group than just a kind of webinar format. So encourage you at least after the presentation is done, to come on camera if you don't mind, um, and help to make this interactive. So our presenter today is Gul Saeed, who is a fourth-year PhD candidate in the Department of Social and Behavioral Sciences at Yale School of Public Health. Her research focuses on maternal and adolescent mental health, suicide prevention, and implementation science in low-resource settings, particularly in South Asia. And drawing on qualitative and participatory methodologies, she examines how social, cultural, and structural forces shape experiences of mental distress and access to care. Her work is guided by a commitment to elevating the voices of people with lived experience of mental illness and to challenging dominant narratives that silence, marginalize, or pathologize their experiences. Gul's presentation today is titled Application of a Qualitative Rapid Analysis Framework in a Hybrid Type 2 Implementation Trial for Suicide Prevention in Pakistan. And Gul has asked, if you don't mind, we will do questions at the end rather than mid-presentation. But it's such a small group. If it's urgent, I'm sure we can accommodate, but that's the preference. So Gul, thank you so much for being here, and please take it away.
Yeah, thank you so much for the introduction and for having me here today. And thank you all for joining. And yeah, since it's such a small group, I think it would be great. I'm totally okay. If anyone wants to unmute, you have like a thought or have a question, we can just make it very discussion based as well. So yeah, I'm gonna get started. So our suicide prevention intervention is called Khushhal Pyramid Zindagi, which means happy, hopeful life in the local language of Urdu. And today I'll be talking about how we applied a qualitative rapid analysis framework in this implementation trial. This is our wonderful research team based out of Yale University and the Global Institute of Human Development in Pakistan. So, just to provide some background, more than 800,000 people die by suicide every year, with up to 75% of these deaths and attempts occurring in low and middle income countries. The burden is particularly stark in South Asia, where women have recorded some of the highest suicide mortality rates in recent years, and where suicide accounts for up to 20% of maternal deaths. Yet, despite this burden, less than 15% of suicide research is conducted in low and middle income countries, leaving major gaps in our understanding of risk, recovery, and prevention in these contexts. We also know that these pathways are not universal, and risk and recovery looks different across cultures, which is shaped by social, economic, and gender realities. Suicide burden in Pakistan is it's known that it is estimated 15 to 35 people end their lives every day, which is as high as one person every hour. And Pakistan is the fifth most populous country, but despite this and their growing burden of suicide, there has been a lack of attention to this matter. Until 2022, suicide was criminalized under the Penal Code 325, contributing to underreporting, limited research, and significant barriers to help seeking and disclosure. This ultimately led to a substantial gap in evidence on suicide, particularly regarding community-based systems for early detection and response to suicidality. However, at the same time, Emerging evidence from Pakistan highlights the promise of community and peer-led approaches, with women, community health workers, and peers demonstrating effectiveness in delivering high-quality, evidence-informed care in similar contexts. This is occurring alongside growing political commitment to mental health, including the National Mental Health and Psychosocial Support Implementation Plan for 2025 to 2030, which signals increased prioritization of system-level strengthening in Pakistan. Combined with a relatively robust health system, infrastructure, and expanding implementation research capacity, Pakistan offers a critical setting for advancing suicide prevention research that is both scalable and contextually grounded. So for our hybrid type 2 community co-design pilot cluster randomized control trial, we had three aims. I will briefly go over each aim more in depth in the following slides, but this is just an overview. To provide some context for our study site, this study leveraged nearly a decade of community research relationships and longitudinal data for an umbrella maternal child cohort study called the Bachpan Study in a sub-district of Rawalpindi that investigates the effects of depression on socio-emotional development of children. Participants resided in the 40 village clusters that comprise the rural sub-district of Rawalpindi, the area which is shown in red on the map here. This figure over here provides an overview of our three-phase study design, which was developed using an overarching decolonial approach. We conceptualized decolonizing as first centering the voices and lived experiences of Pakistani women. Second, acknowledging the historical and colonial legacies that continue to shape power dynamics, knowledge production, and access to resources. And third, co-designing the research with a community advisory board composed of women with lived experience of suicide from our study communities. Importantly, the community advisory board is embedded throughout all phases of the study, as you can see here at the bottom of the figure. So we had 4 to 6 members with lived experience comprising this community advisory board. In phase one, we conducted qualitative interviews with mothers and health workers to understand local perceptions, needs, and priorities related to suicide prevention. And then findings from this formative work informed our phase two, where we culturally adapted the intervention, developed implementation tools, and trained delivery agents, which were the peers, through a co-design process. And then in phase three, which will be the majority of the focus today, we conducted a cluster randomized control pilot trial comparing enhanced usual care, which is the control group, with the intervention package. The intervention includes screening, collaborative safety planning, and a structured follow-up contact. Throughout the trial, we collected qualitative and quantitative data at baseline, midline, endline, while also evaluating key implementation outcomes. So for AIM 1, grounded theory development and intervention targets were informed by the qualitative formative phase, as I mentioned, where we conducted interviews with mothers and health workers. Importantly, we anchored our grounded theory development in a critical feminist epistemology informed by Muslim feminist scholarship and centered participants' lived experiences throughout the analytic process. This resulted in a grounded theory of maternal suicidality in Pakistan, in which we identified four key dimensions of suicidality. So, dimension one is women's in-laws' home creates an intolerable and lonely ecosystem. Dimension two, women's struggle negotiating the morality of motherhood vis-a-vis psychological and social suffering. Dimension three, patience and longing for peace. And then dimension four was religious faith anchored woman's value for life and her afterlife. So this was our aim one. The outcome was this grounded theory of maternal suicidality. And then in aim two, our team engaged in co-designing the suicide prevention package. It comprised three parts. It started with the screening using the 3-item patient safety screener administered by the lady health workers, also known as community health workers. Safety planning and contact follow-up. Informed by our formative qualitative work, the intervention sought to target hopelessness, helplessness, and connectedness. And then finally, for AIM 3, we conducted a pilot hybrid type 2 cluster randomized controlled trial where we applied the rapid analysis framework, which is the focus today. So before describing the outcomes, it's important to note that this evaluation used a multi-method convergent parallel design with embedded ethnography. Our research staff worked alongside the peers who were the implementers and the other implementation teams, such as health system clinicians as well as lady health workers throughout the study, which allowed us to capture implementation as it unfolded in real time. We also used qualitative methods throughout the project, so highlighted here in yellow, not only just for longitudinal interviews that are shown here, but also to develop and culturally adapt all of our quantitative measures. For example, rather than relying solely on the traditional agree and disagree Likert scales, we because they produce social desirability effects and bias in our context, we asked participants how frequently specific behaviors occurred. And we also, based on interview feedback and talking to lady health workers and peers in the community, the time framing when we ask questions, we also adjusted those so that they were more understandable for women in the communities we work with. This approach generated greater variation and more meaningful responses. And then, consistent with hybrid type 2 design, we evaluated both implementation and maternal outcomes. So, on the implementation side, we assessed feasibility, acceptability, appropriateness, self efficacy, competence, fidelity, using a combination of measures, enact ratings, checklists, and periodic reflections. Most implementation measures were collected immediately after training and again at endline, approximately 6 months after the intervention initiation. And then on the effectiveness side, we assessed maternal outcomes, including suicidal ideation, suicidal behaviors, depression, healthcare utilization, and lived experiences of recovery at baseline, 3 months, and 6 months. Longitudinal qualitative interviews complemented the quantitative data, allowing us to understand not only whether change occurred, but how and why it was occurring. So why did we use rapid analysis in our hybrid type 2 implementation trial? So our embedded longitudinal approach generated a rich stream of qualitative and implementation data. The challenge here was not collecting the data, but transforming these data into timely insights that could inform ongoing implementation decisions. The key question was, how do we identify implementation barriers and adapt implementation strategies while the trial is ongoing rather than waiting until the end of the study? This mattered because emerging barriers can directly affect how the intervention is delivered in real time. If feedback is delayed, we lose critical opportunities for course correction. In hybrid trials in particular, there is a need for timely evidence that can actually inform implementation decisions as they are happening and not retrospectively. And then another key question that we had was, how do we efficiently process and make sense of these large volumes of qualitative data generated throughout the trial? We were dealing with multiple data sources collected across different implementation phases, which creates a constant stream of information. And at the same time, we just didn't want the data just sitting there. The challenge was ensuring timely analysis without compromising rigor. And traditional qualitative approaches, as many of you are familiar, often are not fast enough to produce findings that can actively inform ongoing implementation. So then we wanted to avoid the gap between data collection and actionable insight. So to address these challenges, we embedded a rapid template analysis framework within our hybrid type 2 trial, allowing us to generate timely and actionable insights to support implementation decision-making throughout the study. Some of you may already be familiar with this approach, but just as a quick background, rapid qualitative inquiry is defined as an intensive team-based qualitative inquiry with a focus on the insider's perspective using multiple sources and triangulation, and using iterative data analysis and additional data collection to quickly develop a preliminary understanding of the situation. In practice, this is an efficient approach that enables iterative refinements of methods while still maintaining rigor, using relatively minimal time and resources compared to the more traditional qualitative approaches. More specifically, our approach was heavily influenced by Tracy Abraham and colleagues' three-phase rapid template analysis. In their approach, there are three phases. First one is focused on data reduction and standardization. Phase two is matrix displays and synthesis. And phase three is summary tabulation and pattern identification. In the later slides, I will show you how our team used these. This approach was a particularly strong fit for our trial for several reasons. First, the trial required us to generate implementation insights while the intervention was ongoing rather than only at the end. Second, we needed to continuously synthesize data from multiple qualitative sources. Third, these insights had to be produced quickly enough to inform our ongoing implementation decision making. And finally, this approach allowed us to be responsive to Pakistan's sociocultural, religious, and legal context, which is shaping implementation in real time. So table 2 here just summarizes the range of qualitative data sources and collection methods that we were using across our different implementation levels that informed our rapid analysis. So here at the top, at the broader contextual level, we captured the social, political, and economic environment. Data were documented through ongoing implementation tracking. This included supervision notes, team debriefs, and key implementation related events that shaped delivery over time. And then at the health facility level, data sources included facility visit records and information on clinician turnover. These were captured through tailored tracking forms and regularly monthly field visits where our field coordinator would collect the facility records from the medical officer or the LHW working at the basic health unit. And then at the level of health workers, which included medical officers, lady health workers, and lady health supervisors, data were generated through monthly meetings as well as in-depth interviews. So our team held monthly meetings with particularly with the LHWs and their supervisors to get updates from the field. And in addition, supervision debrief templates were completed after these meetings, along with post-intervention focus group discussions to capture reflections on implementation experiences. And then at the implementer level, which included peer mothers and peer supervisors, data collection was more continuous. This involved biweekly supervision templates, periodic structured reflections completed twice for each peer, and post-intervention focus group discussions to capture their overall experiences and implementation challenges. Finally, at the participant level, mothers in the intervention group were followed longitudinally through repeated in-depth interviews, allowing us to capture changes in experiences and perspectives over time. We also conducted online interviews with the control group mothers. And then for data analysis, we first used deductive coding based on predefined implementation domains, and which allowed us to structure the analysis around established areas of interest from the outset. Second, we developed matrix-based structured summaries of the qualitative data, which helped us systematically organize and compare findings across data sources and implementation levels. Third, we relied a lot on team-based interpretation and triangulation to ensure emerging findings were continuously discussed, validated, and refined across the research team. And then in terms of outputs, this approach generated rapid analytic memos that captured emerging insights in real time. These were translated into actionable and implementation briefs to directly inform decision-making during the trial. In addition, we produced real-time feedback that supported ongoing refinement of implementation strategies as the study progressed, and this primarily occurred at our weekly team meetings. To give a quick sense of how the rapid analysis process worked, particularly for our trial, I'll be sharing what we followed for analyzing periodic reflections for the implementers, so the peers. In the first stage, within 1 week, the primary coder would review the reflection field notes in detail, familiarize themselves with the data and the coding domains, and then begin populating a structured qualitative matrix with emerging insights. And the coding domains came directly from our periodic reflection guides. So the questions that we had were informing the coding domains. Relevant implementation domains were also flagged in the sheet. And these were informed by the Consolidated Framework for Implementation Research, also known as CIFR. So we use those domains such as inner setting, outer setting, intervention characteristics, characteristics of the individual. And then in the second stage, over about 3 days, a second coder from our team reviewed the synthesis in the qualitative matrix, added detail where needed, and noted any areas of disagreement or divergence from the primary coder, ensuring quality and consistency. And then to differentiate between the coders, we just used a different color font, kept that pretty simple. In the third stage, also over 3 days, the primary coder consolidated these inputs into a rapid summary sheet that captured emerging themes across reflections. I'll be sharing examples of those sheets so you'll have a better idea in a bit. Finally, on a monthly basis, here at the end, stage 4, the full qualitative team met to discuss patterns and refine both the interview guides and analysis process. Our supervisor, Dr. Hageman, also reviewed selected reflections each month. And on a quarterly basis, findings were shared back with the peers and the community advisory board for further input. And then this is just an overview of the steps that I just described. So to ensure rigor and consistency, because there were so many data streams and we were collecting all this data, we also drew on the planning for and assessing rigor and rapid qualitative analysis checklist using structured summary templates to guide and document the rapid analysis process. So as mentioned, for implementers, we use periodic reflections that were paired with supervision debriefs to systematically capture implementation experiences over time. So here is just a picture of our periodic reflection interview guide. We had several domains, so check-in, case updates since last periodic reflection. As mentioned, we did 2 periodic reflections per peer. So one was early on in the intervention after they had delivered a couple sessions, and then one was after their final session had been completed. We also probed for adaptations to KPZ intervention, adaptations to the mother and family engagement, which was a critical part of delivery. We also captured how the broader environment and context were influencing implementation, as well as reflections on peer supervision and training experiences. And then once we had that feedback, we would share it with the peer supervisors and they would adjust then following training sessions and supervisions accordingly. And then if time permitted, we had additional domains such as collaboration around the safety card, any unexpected barriers that emerged, and any new facilitators or helpful practices that were identified during implementation. And then this is what our periodic reflection summary template looked like once it had been filled out. We ensured that all the details were captured. So the qualitative interviewer would complete these within 24 to 48 hours after they had completed the periodic reflection, so as to keep everything so they could add as much detail as possible. And then we ensured that they would retain actual quotes from the participants. And when needed, they would go back to the recording. So these periodic reflections were also audio recorded if the mothers permitted, or the peers permitted, sorry. Then they would go back for quality checking and ensure that every detail was captured accurately. And then this is just an example of the templates that we developed for peer supervision debriefs as a way to triangulate data for challenges encountered and how they were being addressed. So in addition to capturing data like such as barriers the peers were facing in their individual periodic reflection, we also spent time during the supervision sessions discussing challenges so that the peers could hear from their other women in the community who were delivering the intervention, what kind of challenges they were encountering. So it was kind of a mutually beneficial learning experience. And also at the same time was helping us triangulate the data with the periodic reflections. And then the next couple slides are for the recipients. So the longitudinal qualitative interviews with a purposive sample of mothers. This helped us to understand participants' experiences of the intervention and the mechanisms of change for our intervention. And the intervention participants, as mentioned, were interviewed at 1 month and then again at 6 months post-enrollment, which was the end of the intervention, while control mothers were interviewed at 6 months only. In addition, we collected ongoing implementation data through field observations. So that was done by the peers, LHWs, or the peer supervisors, assessment records, as well as peer case logs throughout the pilot trial. And then here is just an example of our baseline interview guide, a part of it for the intervention moms. Our intervention guides were designed to explore both psychological outcomes and intervention experiences. We examined changes in key mechanisms identified in our grounded theory from AIM-1, including hopelessness, helplessness, loneliness, belongingness, and patience. We also explored participants' experiences with the core intervention components, such as peer support, safety planning, and intervention activities, to understand what aspects were most meaningful, acceptable, and useful from the mother's perspectives. These longitudinal interviews allowed us to capture how women's experiences evolved over time and provided rich insights into both intervention effectiveness and implementation. And then in the next slide here, we have the baseline interview summary template that comprises all the domains from the interview guide. The interviewer filled out these templates, again, similar to the periodic reflection, 24 to 48 hours after the interview, and provided rich detail, including verbatim quotes from the participants. This is just an example of the participant description captured in the summary template. The templates were very small and difficult to read, so I'll just quickly share a part of this. This is what the qualitative interviewer wrote after the interview. Quote, her shoulders dropped and she started looking tired and defeated when I introduced myself. Throughout our interview, she constantly tried to avoid any eye contact or to initiate any conversation. Instead of looking towards me or interacting, she tried to be busy with her kid as if intentionally trying to avoid me, unquote. So that's the type of rich detail that we tried to include in our summary templates. And then just another example of important detail or quote captured related to perceptions of the intervention efficacy, as a participant shared, quote, my main issue was severe anger, bahut gussa. I've seen so much improvement in it. Alhamdulillah, showing her gratitude for her improvement. This week, I rarely felt angry, and whenever I did, like yesterday, I left the room my mother-in-law was in and did that breathing they taught me. Then I got myself in cleaning my son's room, unquote. So next, moving on to the qualitative matrices, the step that we did after we had filled out summary templates from the different interviews. Again, we used the planning for and assessing rigor and rapid qualitative analysis checklist to inform the development of these qualitative matrices. The matrix was designed deductively to align directly with our interview guides and implementation domains, so the CIFR. Domains were clearly defined a priori while allowing for refinement throughout the analytic process as new insights emerged. A senior qualitative analyst oversaw matrix development and data entry, and weekly team meetings were held to review findings, ensure consistency, and discuss emerging interpretations. This approach enabled a systematic and rigorous analysis while maintaining the efficiency required for the rapid qualitative research. So in the next couple slides, I'll just walk you through the different matrices we developed for end-line data for intervention mothers, just as an example. So here we have our qualitative matrix for the end-line intervention moms. At the top row, we have the domains that directly align with our interview guide we had. And then on the first column, we have the participant ID. And then as you can see here, we have each column is with different interview questions, but importantly, between that, after each interview question, we have notes and analytic statements. So whenever the primary coder and secondary coder had any disagreements, they would write here. If it was an analytic statement, it would be in black font. Otherwise, it would be in red. So yeah, this was kind of our way of organizing and communicating across different people on our team. And then each row is a different participant ID. So here we have ID 207, ID 134, and so forth. And then just as an example, This is the type of detail we captured in the matrix. Key details from the summary templates. Off note, beyond informing implementation, our rapid analysis also provided early insights into how the intervention was working. As shown in this quote here, one of the strongest findings was the value of peer support, with many women describing their peer as a trusted confidant who reduced feelings of isolation and loneliness. So as one participant described, quote, because of her, the peer, my whole life has gotten better. She's perfect the way she is. I never hid anything from her. I told her everything. She had explained that these things like knives, pills, guns can cause harm and should be kept away from the house. She also told me to do breathing exercises that they help lighten the heart. She said, when you're angry, go somewhere else, watch TV. Don't talk back to your husband in anger. A few months ago, I got angry at something my husband said, but I controlled it. He was in the room. I got angry, so I left the room. The TV was on outside. I started watching it. When he left the house, I went out into the courtyard and lay in the sun. So the fight didn't get worse and the anger passed too. Unquote. So we tried to capture these kind of details and quotes in our qualitative matrices, and this was under the section about intervention elements. And then subsequently, a condensed summary of the data was developed from the matrices, which allowed us to bring together and synthesize findings in a structured way. As an example of recurring themes from the N-line interviews, this is the N-line interview summary sheet. So you see here at the top, there's the interview domain, recurring themes column. We have also direct quotes from the different participants, and then brief analytic summary for each of the interview questions. So just as an example, for recurring themes for question 2 here, we identified that so question 2 was asking how are you doing, and we probed for targeted mechanisms of hopelessness, helplessness, loneliness, belongingness, and patience. And many participants described feeling hopeless and helpless before joining the program, often due to poverty, illness, domestic conflict, or lack of spousal support. Several spoke of wanting to, quote, go away somewhere, unquote, or feeling that, quote, nothing is in my control, unquote. So the theme we identified here was reduction in hopelessness and helplessness as a result of the KPZ intervention. And then another theme we identified was improved emotional regulation and anger management. I've just written it out here. That's essentially the text on the right is what we have here for the first row. And then we follow the same process for other groups. So like health system clinicians, like the medical officer and lady health workers, as well as peers. And then in addition to the matrices and summary sheets, something that really helped us was we maintained different tracking sheets in parallel. Their main purpose was to help us keep a live record of what was changing during implementation. So these different tracking sheets helped us maintain a documented audit trail. So here we have the qualitative guide monitoring system. An example of change we made to the interview guide, all those were documented here, along with the rationale of why we're doing this change, and then steps to make that management. And then we also had one for adaptations to training. So for example, often adaptation to training that we documented in this tracker was there was difficulty providing in-person feedback to peers on practice cases due to time constraints and scheduling between the peers and peer supervisors. And then it was hard for our team to get to the women and vice versa because women don't have much freedom of movement and thus cannot leave their house on a daily basis or travel long distances. So after discussing this challenge at our team meeting, a suggested modification was add an asynchronous way of providing feedback to peers on the practice cases. So our team did that through voice notes on WhatsApp. And then we also document the rationale as well as the date these changes were made in these trackers. And then another tracker we had was adaptation to sessions. Here, just an example is that in session 1, peer supervisors accompanied the peers to the mother's house during the first session, which caused a lot of noise due to extra people being present and created distraction. A suggested modification was that peer supervisors will not accompany the peers to the mother's house. And then the rationale was to minimize noise and distraction during the mother's session with the peers. So we document these in each of these different columns. And then we also add which team member added these, as well as the dates that these occurred on. And then lastly, we also had an implementation tracking for outer setting and contextual factors. I've been mentioning a lot about the outer setting and contextual factors affecting implementation. So here's just an example. Something that we documented here is that Islamabad protests led to closed roads and shut down internet for several days around the city. The team meetings and field work was canceled for a week from November 24th to 28th, 2024. And then action taken was we just resumed field work when feasible and safe. So yeah, these different tracking sheets helped us maintain a documented audit trail of what changed, why it changed, and how the team responded throughout the implementation process. This was especially helpful given that this is a pilot trial where ongoing refinement and adaptation are expected. But beyond supporting the current study, this documentation also generated valuable lessons for a future trial by identifying common implementation challenges, successful adaptations, and areas where study procedures could be strengthened before scale up in Pakistan. So yeah, I'm just going to briefly share some key findings of note. So in terms of some of the key findings from our pilot trial that we found through the summary matrices is one of the most consistent themes was how peer support reduced isolation and created a strong sense of belonging. Mothers describe peers not just as facilitators, but as trusted confidants. Flexible scheduling also played an important role in keeping women engaged. So, for example, sometimes the peers, every time there was a session, the peer would make sure that the mother is not busy and it aligned with her schedule between her domestic duties, duties for her children, and any other tasks she might have. And overall, mothers repeatedly emphasize the value of being listened to without judgment. For many of these women, they typically did not disclose their suicide to anyone, except maybe their mom or sister. So having a peer listening to them was also very beneficial. And then we also saw a lot of descriptions of improved emotional regulation. Mothers describe being better able to manage anger and distress in everyday family situations. For example, one mother shared how she was able to step away from a conflict, as you saw in the quote, and use distraction as a strategy. This reflects greater confidence in coping with emotional distress and handling interpersonal stress more constructively after receiving the intervention. And then a third key finding was that safety planning was not just understood conceptually, but translated into everyday action. Mothers described using breathing exercises, leaving escalating situations, and relying on self-soothing and distraction strategies in real time at home. This suggests that the intervention supported practical coping strategies that were actually taken up in daily life and may be of beneficial to the moms. And at the same time, it is important to note that some mothers did express that structural challenges remained. Issues such as poverty, family conflict, and limited autonomy continue to shape women's lives. For some mothers, feelings of hopelessness persisted despite the psychosocial gains from the intervention. And then I described a lot of the rapid analysis and like what may seem like it's like a smooth and seamless process, we did encounter challenges. One of the things was that we encountered was managing the sheer volume of data, qualitative data being generated across multiple participant groups and data sources while producing findings quickly enough to inform ongoing implementation. We had one main primary coder and then one secondary coder. So just having two people working on all this data, it took longer than like each time. It wasn't like a perfect timeline. So sometimes it would take longer to process all of that. Because one of the goals of rapid analysis is to provide real-time feedback, there was a constant balance between analytic depth and the need for timely synthesis. And then a second challenge was the risk that less prominent, unexpected, or minority perspectives could be lost during data reduction and summarization, especially when we do the summary in the summary sheet. We take the themes that are recurring more commonly So if one or two participants may have mentioned a challenge that may get left out, so there was that risk. To address this, we incorporated regular team discussions and iterative review processes and opportunities. Especially because the peer supervisors were so familiar with what was going on in the field, these meetings really helped us. So if something was missing from the summary sheet when they were being presented at the weekly meetings, the peer supervisors would typically catch that. So yeah, this brings me to the end. Thank you. I do have some discussion questions, but before that, if anyone in the audience has questions or has anything to share, I would love to hear from you.
Great. Thank you, Paul. All right. Looks like Julia has a question.
Hi, Gul. Thank you so much for sharing this work. And this sounds very interesting and incredibly rich. So, my question is, now that you have gone through this experience, do you feel that there is some way that you could tell retrospectively that, we could have not done this and this and this and this at all, just because we could have had a similar amount of results of rigorous quality, even without, doing all of that? Because what struck me is that even though it's called rapid qualitative analysis, it's a lot of work and it's very intense, requires a lot of time and people. And like, is it always affordable to do it like that? So that's my main question. Like, do you have a sense of what kinds of steps from what you described you could have just skipped completely, or lightened up so that you could do almost the same, maybe not exactly as perfect, but almost the same. So it would be like not like A plus, but A, and it would have been fine. So,
Yeah,
if you have any,
that's
yeah, if you have
a
insights, please do
that's
share.
a that's a great question. Yeah, it does like when I was even making this presentation, I was like that. And like I was talking to Dr. Hegeman, she's like, "Is this rap?" Like we were both like, "Is it like this is a lot of work?" We did all that. But I think looking back, our qualitative interviewer, she would have to fill out the summary template after the interviews. And essentially, what I was doing was going and looking, reading that summary template and adding that to the Excel sheet, which was the qualitative matrix. And I feel like that was kind of like repetitive. Like she would add all that information in the summary template, and then I would extract that. But I felt that when I was extracting that information from the summary template, um, I ended up adding a lot of detail to the qualitative matrix for each participant. And because the domains in the qualitative matrix are aligning with the interview guide, I do wonder if, like, if the qualitative interviewer could have just directly added that information, like very, very important points to the matrix directly, instead of like having that whole like extensive summary template and then extensive qualitative matrix for each person. I think those two steps can somehow work in parallel to reduce that time that it takes. Yeah. I think Karen has a question.
Hi. Um, I feel like it's always important to preface with the fact that I'm an anthropologist. So, when it comes to qualitative data, our approaches to understanding may differ a bit. And so, I guess my question is, um, like in terms of qualitative data not being fast enough in terms of like the rapidity with which you want to turn it around and operationalize. I guess because we take our time because I think that one is understanding the proximate and ultimate causes of behavior and what drives things and the complexity of all sort of these intersecting points. And then the other is sort of differentiating between the fact that what people do, what they say they do, and what society tells them they should do are often very different. And so understanding how people present and getting to that trust and nuance also takes that time depth because things change over time. And so I wonder how much, because you had said that you're sort of basing this on a 10-year relationship that pre-existed. And it
Yeah.
sounds to me like you had some emic and etic perspective, so insider outsider stuff going on. So I wonder if you had come in cold, sort of into a new community, if you feel that this approach would have been representative, and if you would have been able to move at the speed with which you did in terms of transforming findings to implementable results or changes.
Yeah, no, that's a great question. I have, so I guess I can speak from my experience. So I was previously working with the team on this suicide prevention project, but now I'm doing like an independent project for my dissertation in Islamabad. So like a same city, but I'm not like attached to like the Global Institute of Human Development that has like a decade long partnership, in the communities. So I think just experiencing like doing the rapid analysis in like for the KPZ suicide prevention trial versus now when I'm studying like adolescent depression and anxiety, a different topic. Working in the same city, but not having like that like institution, that has like decades long of partnership. I don't think that I could use this same framework for my dissertation because like you mentioned that like trust building that comes with like the name, like when we tell them like, oh hey, we're from the Global Institute of Human Development. We've been working in your community. We've done these programs here. The lady health workers in the communities like instantly recognize by the name. Like, oh, we worked with this institution, so they're trustworthy. But like now that I'm working kind of like independently, I do like have like that outsider perspective where I'm like, okay, like I can't just go and like interview all these people like in like a short span of time and then inform my study. So that is taking time. So I guess like I kind of got like both experiences where I'm working with like a larger team that has that like partnership and like so much experience in the community versus now where I'm working like on a new topic and like kind of like independently for my thesis. It's been like there are like new challenges. So I'm not using this approach because there's no way you can collect so much data without building that rapport. Yeah. I hope that answers something what you're saying. Yeah.
Well, hi, I was wondering, and this might be, I think it's actually probably related to both questions so far, but um, w was there overlap between sort of the data that you were collecting and maybe I'm going to say clinical data that the lady health workers were collecting? So was it the same type of data, same frequency? And I guess I'm just thinking about it because I've been involved in interventions, right, with community health workers where, they have you're sort of like feeding two systems at the same time. And I think that's also one of the things that happens in terms of efficiency and response and who knows what at what point.
Yeah. So in our trial, the lady health workers, they were not delivering the intervention. They would help us early on by administering the patient safety screener. So help us connect to women who would potentially be eligible for the intervention. And then they would help the peer who would be delivering the intervention. They would introduce that peer to the family. So beyond that, they weren't collecting any data.
Okay.
Um, yeah, so it was the peer supervisors as well as our team that was primarily our assessment team that was collecting the data. Because it was like a relatively new topic to that community. Previous work on suicide hadn't been done there. So there wasn't kind of like multiple data like being collected on the same issue. Yeah.
And then were the peers, and I mean, you presented such a wealth of data. Was this all of the data that the peers were collecting, or did they have other data that they had to collect as well?
So the peers were collecting, so they have case logs where they write information after each session, and the case logs were collected by their peer supervisors. And then the peer supervisors would upload the case logs and case files on our box, and our team was processing that data.
Was parsing the data. Okay.
Yeah, yeah. So the peers didn't process any of the data. They had their case files and case logs that were filled out after the sessions, and then it was our team that would process everything.
Okay.
Yeah. And then as for the qualitative components, we had a qualitative researcher who would be doing the interviews. So there was one person who would be doing the qualitative interviews, including with the mothers, as well as the focus group discussions and the periodic reflections. And then I was interviewing the peer supervisors. So there was like me and this other person on our team who was managing the qualitative side, and we were basically the two people doing all the qualitative data collection and analysis. Yeah.
I mean, given I have to say I sort of agree with what Julie was saying, like it's this enormous amount of data that you're managing. Was there anything that you felt sort of in coming into it that you thought, um, I guess the flip would be, was there anything you felt you were missing, right? To Karen's sort of point about being like in center efforts. Was there anything that you sort of got to the end and thought, oh, I have a lot of this, but I don't have any of this?
Hmm. I think one thing like was that I realized during our team discussions is when I was extracting from the summary templates, putting it in the matrices, and then like the summary matrix where you extract kind of like everything from across the interviews and like put themes for each of the interview questions or domains. Things that participants share, like one or two participants share, like for example, like structural challenges, they might get missed out on. So for example, like some participants shared, I'll go back here. It was a neat example. So like one participant, like here I write, however, a few continue to experience persistent distress and hopelessness. So while the theme is reduction in hopelessness and helplessness, it didn't like we didn't add this till later after discussing in the team when like our peer supervisors were like, oh, like not everyone shared that, they had reduced hopelessness or helplessness as a result of the intervention. So we need to capture these like one or two mothers who are also like explaining that, hey, like the intervention didn't reduce hopelessness or helplessness because like I'm still in poverty, I still can't put food on my table. Like those factors were not changing. So then I went back and like added this information. So there was that like for like a while when I was first doing these some master summaries, that kind of information, which was not commonly reported, was getting missed out on. But then I think like talking it through with peer supervisors who are much closer to the field, because they do like visits and are in contact with the peers. I learned like, like these experiences also need to be captured. So we decided to add them as well, even if one or two people were reporting it. But I think like if we didn't have those discussions, like this information, it's like easy for it to get lost because we're like focused on like the main themes or common themes reported across the moms. Yeah.
Yeah, absolutely. Yeah, and I think that's also a really interesting way. Um of thinking about how do you report uh negative finding, right? Like how do you report negative findings in an extremely um
Yeah.
uh I would say structured approach, right? Where's the room for making sure that
Yeah.
there's room for that?
Yeah, for sure.
Do you want to put up your questions for the
Yeah.
audience again? Yeah.
Yeah, I was just I guess one of my questions was if anyone here has like experience using a similar approach, what do you see as the biggest risk to rigor or validity, and what safeguards have you found most effective to address it? Just because as we all like just talked about, like there's just so much data and things get left out, but what kind of safeguards have you found most effective to address that?
I mean, I think this was a massive undertaking. It's kind of like you're trying to eat an elephant all in one bite. And I guess to me, it's always curious about like what's the purpose of each thing. So into implementation science, because for something like this, I would have looked at like PDSA cycles, which are really clean and help you describe everything, or like Pawson's and Tilley's realist evaluation, which allows you to sort of change and pivot in time. So yeah, I guess it's so hard because qualitative data is so about time, depth, and understanding nuance. And so trying to do both those things at once must have been very overwhelming. And I
Yeah.
don't know if there's a way where you can get that depth with that speed. Like I just feel like I mean, maybe doing two parallel trials where you're doing sort of analyses from both to
Yeah.
inform, especially the realist evaluation. Those are super helpful.
Thank you. I will look into that.
Yeah, I sort of think I know you're asking question two, but actually I sort of think that question one and question two might be pointing in the same direction, which is
Yeah.
that I think that the risk is losing nuance. And the risk is sort of doing being so structured as to lose the strength that you will have, which is that you do have a lot of nuanced and complicated data, and that is a real strength to your study. And that is a huge, huge asset for you. Especially because this is new, right? Like it's like a really messy gift, right? Because they're like, this is new. And so to find all of this out is the first time you're doing it is a good thing. I would sort of actually be really worried about being so focused on integration that you lose that you sort of make it too neat, if that makes sense.
Mhm.
And I think, I think you have really demonstrated your rigor by, there were a lot of structured processes, but also processes that involved, it sounds like every person and group, like it does from the way you sounded, it didn't sound like anybody was left out. Like you were reaching out to all different people at all different time points, which I think is really important to your rigor. I flinch a little at the validity and think more about things like trustworthiness and, those kind of things, that to say, like, maybe leaning to sort of look really leaning in at the qualitative strengths of this. So when you
Mhm.
share the findings with your peer supervisors and the community advisory boards, like, what were their responses? You know what I mean? Like, to lean into that as, like, that's how you're assessing, like, um, their
Mhm.
feedback in those moments, and looking at how many people completed the intervention, and you know, what their experiences were. They don't, to Julie's point, it doesn't always have to be A+ to be
Yeah. Mhm.
worthwhile and good and meaningful. So I don't
Yeah.
know. It's a little rambly, but I would maybe think about leaning into that nuance and complication as one of your strengths, rather than worrying about making it so neat.
Thank you.
Yeah, so I'm just thinking in terms of question one is along the lines of this discussion or conversation that we've been having, like how can you trust that even if you are, let's say that you're not losing nuance, but you're just putting it aside. How can you be sure that you can trust yourself or whoever is doing that, that it's okay to do so, that it's still very good, and it's probably the best for this particular moment. That's exactly what you need, and doing more would not be better. So I don't know. It seems like it's something about the DNA of the project, or maybe about the team, or something like that, where you have this absolute confidence that you get it. You don't have to like get through all those tables and templates and forms and things. You just take a look, and it's kind of like, that's what the question was that I believe Karen was asking, like if you've been in that space long enough, but then, of course, you have to kind of stop and say, well, am I reading into things? Because that's also a possibility. You can be very sure that you know what it is like and, why things are working or not working, but you might be mistaken. And so I suppose that the real sort of challenge and biggest task is to get to that sweet spot where you are comfortable with, like understanding it just deeply enough. And once you get to that point, that's what I think Meredith was talking about, the trustworthiness, like who you can trust with making that judgment call. Can you trust yourself? And then how do you know that you can trust yourself with that? Like how do you know that you're right in what you have thought about,
Mhm.
in saying that these are the three key things, that's why everything is working, or that's why nothing is working, these are exactly the problems, and I know. And then somebody says, well, how do you know? And you say, well, I know because, and then you have to give them something like that, right? So I guess that's to me would be sort of how you would need to explain it. The problem is that I have no idea how to arrive at those answers to those kinds of questions, so that's really complicated. I think it will become even more so as the field, and I'm horrified, to be quite honest, by how well you've done this work, because I'm thinking, oh my God, like if I have to do something like that in the context of our projects, I'm doomed because this is a lot, and it's very complex and it's very labor intensive. And I think that the field is moving towards making it kind of like a thing. You have to do all those things. You have to do all those forms. You have to do all those matrices. I've never done them in my life. And I was hoping that, I wouldn't have to till I retire. Now I see that maybe I'll have to do them tomorrow. And it's like, good grief, that's too much. It's like,
I share that too. Yeah, it's
oh,
a lot. Like
Yeah,
so many checklists, so many guidelines. Yeah.
I mean, that's I think maybe the question is, do you feel like all of those forms, doing all the forms and the matrices and the guidelines, like did you see a benefit in doing that? Did you experience a benefit? And it's something that there might have, but so I'm like, for you, as you were doing that, what was the benefit or the help to the study for that?
So I guess one thing was that it made me like so close to the data that like now I just like know like each participant's case and like when I did so I would go to the supervision meetings as well. So having like that background and kind of like studying those like summary templates that the sorry, yeah, like the summary templates that the qualitative interviewer fills out, it helped me understand the peers' cases like in more detail. So when they were explaining like a challenge, that really helped me. I didn't have to like, it just brought me much closer to their cases than if I had just attended like one or like, because I didn't go every month to the supervision. Like I wasn't always here. I was sometimes at Yale doing coursework. So it was like back and forth. But reading those kind of helped me because I wasn't on the field all the time made me closer to the field. I think that was like my personal benefit. But as I mentioned earlier, like I think the summary templates that the qualitative interviewer is filling out and then what I'm putting in the matrix, if somehow like there's a way or like it is acceptable that those two steps get condensed, I think that would be like very helpful because it seemed like both of the things were like quite similar, to be honest, because everything is aligned with the interview guide domains. So it's like, oh, like, why doesn't the interviewer just fill this out? Yeah.
I guess that would be my next question. Why didn't why
We were
wasn't that?
following, yeah, so we're talking about it now, like, like how can we make this process seamless? What are like things that could be like changed? We haven't like had like a chance to discuss with the whole team yet, but we didn't do it because we were following like certain guidelines, like I shared, and like the template analysis by Tracy Abraham. So we were following like their three phases. And that was like very like you have the summary templates, and then you have the matrices, and then you have the master sheet. So it's like those three steps were important. And I guess like when you write up about these things, like there is this like Julia was saying, like, it's like the field is moving in this direction. Like when you write up, everyone's like, so how did you do this? Like what guidelines did you follow? What were your methods? So like writing everything in like such a structured way. We chose to follow those guidelines, but we are discussing like whether this was really rapid and whether there are steps that could have been left out based on like the qualitative interviewer's experience as well. But that is something that we're still working on.
Yeah.
I think it's probably a safeguard because usually when you are analyzing data, like, so, as an anthropologist, you have to be very aware of your own biases. It's a lot of work and it takes a lot of reflection. So, probably the dual step allows it to not be as influenced by whatever sort of emotive reaction the person is having in the field. And so, I
Yeah.
mean, I don't think it's a necessary step if you sort of
No, it's
support
yeah.
that reflection.
I also wonder if it's to the point like it's a way to have people who maybe physically cannot be there or are joining the team at a different point in the study to
Yeah.
become immersed in the data, right? It provides a way for,
Yeah.
as you said, so
Yeah.
um yeah.
outstanding amount of work, though.
Yeah. And I
Yeah,
think,
in the moment, honestly, because we were just going through like the process, it didn't seem like a lot, but like when we look back, we're like, whoa, like that is like when I was making this presentation too, like, wow, that's a lot. Because I guess we were so used to it and it became like once you start doing it, it became like a quicker process, like especially when I was entering data, like in the beginning, I would kind of be slower, but then it just became like, yeah, just like like it became easier for me as well as the person who was managing the matrices.
but then, and I think, I, I guess my question comes down to though, like, if, so it sounds like there are these kind of benefits to it that add to it, but then do you feel like the processes affected the results in any way or informed your results? Or were the processes sort of more about the workflow? Like to Karen's point, was the reflection process, did that yield different insights or change the findings in any way? Or is it really about how the work is accomplished?
So I think one thing that we did for our like matrix, we had like a column with the notes or like analytical things. So because I didn't fill out the summary template, so if I had like a reflective point, I would add it in that column. Whereas for the interviewer, at the end of the summary template, there's like a reflexivity section that all like anyone doing the interview fills out, like what they were feeling during the interview, what they observed. And then that also, so kind of like the interviewer and I had like our separate like reflexivity part. Yeah, so there was no overlap there. I think it was, yeah, it's a lot to do with workflow, honestly. And I think the reducing bias is having that column in the matrix where you write your own notes and like reflections. And then for the interviewer, it's the reflexivity section. And then I also read the reflexivity section and see if anything is of note. And then we have like an additional comment section at the end of our matrix, and I add it there. So I think it does help in the sense to reduce that bias. And then we make a note if like it's something that actually the participant said versus if it's something the interviewer just observed. So that distinction has to be made in the matrix so that there are like no assumptions. Yeah.
Just out of curiosity, did your information and consent letter include the ability to do secondary analysis on this data? Because I imagine there's a lot of additional querying that you could do.
I'm actually not 100% sure. I will need to check on that. But yeah, I think currently we are using some of this data to write about like a qualitative outcomes paper for our pilot trial. I think, but I'll have to check with Dr. Hageman since I did join the team later after the formative phase had already started. Yeah.
Well, I'm glad we had enough engagement that we are 12 minutes past 1 o'clock. Um, so anything else you'd like to share before we wrap up?
Yeah, thank you all so much. I did take notes. Really appreciate the feedback. I'll share this with my team as well as we discuss for our larger trial. And then, as always, we share mental health resources. This is just some important information. And then, yeah, thank you so much. And I look forward to staying connected.
Thank you so much. Thanks everybody for being here.
Yeah, thank you, Daniel.
Yeah, of course.